Hollywood, the lights, the stars. You can just feel the cortisol coursing through your veins when you step in front of that camera. And when your 15 minutes of fame are up, it all comes crashing down. Welcome to the Adrenal Insufficiency sketch. This is a big topic, encompassing the presentation and management of primary, secondary, and tertiary causes of adrenal insufficiency. Let's head out to the set, shall we? I want you to meet our leading lady, Daisy Addison. Is she okay? She's either having a mini stroke or method acting. Let's just assume the latter. Primary adrenal insufficiency, also known as Addison's disease, refers to disease at the level of the adrenal glands. The glands themselves are not functioning correctly, which results in decreased hormone production by the adrenal cortex. Notice that Miss Addison is on the primary set for primary adrenal insufficiency. Also, the cortical studio sign is broken, representing a broken adrenal cortex with insufficient hormone production. Which hormones, you ask? Well, we've got them all right here. Or we would, anyway, if the cortex were functioning properly. The broken mineral crystals represents decreased aldosterone, a mineralocorticoid. The malfunctioning gate made of male symbols represents decreased adrenal sex steroids. And thirdly, the injured moon depicts decreased glucocorticoids. Recall that our recurring sketchy symbol for glucocorticoids is an eerie moon face, reminiscent of the classic moon facey side effect experienced by patients on prolonged glucocorticoid therapy. Over on the second set, we'll illustrate secondary adrenal insufficiency. This time, the disease is at the level of the pituitary gland, hence the punched pituitary bag over there. The adrenal glands work just fine. They're just missing the necessary stimulation from the pituitary gland. Stimulation which normally comes from the hormone ACTH. Decreased ACTH is symbolized by this broken action clapperboard.
No, cut! I said punch the pituitary. Punch! Even Seal has more real hits than you.
And finally, for tertiary adrenal insufficiency, we're going all the way to the top of the food chain, to the producer. He represents the hypothalamus, which normally produces corticotropin-releasing hormone, or CRH. Not today, though. Or at least not while getting crushed by that runaway prop. Keep in mind that in secondary and tertiary adrenal insufficiency, the adrenal glands still make aldosterone. Yup, the hypothalamic pituitary adrenal axis may be interrupted, but aldosterone production is regulated by renin production via the renin-angiotensin-aldosterone pathway. So, while glucocorticoid, aldosterone, and adrenal sex hormone levels are low in primary adrenal insufficiency, only glucocorticoid levels are low in secondary and tertiary adrenal insufficiency. Keep these distinctions in mind as we work through the presentation, workup, and management of primary, secondary, and tertiary disease. Alright, adrenal insufficiency comes in two flavors: acute, also known as adrenal crisis, and chronic. We'll go over the chronic version first, as emphasized by our recurring chronic grandfather clock symbol. Chronic adrenal insufficiency presents insidiously. Patients have nonspecific symptoms with slow onset, which often delays the diagnosis. Specific symptoms also depend on whether the adrenal insufficiency is primary, secondary, or tertiary. Typical symptoms are fatigue, weight loss due to anorexia, nausea, vomiting, vague abdominal pain, and muscle and/or joint pain. Patients may also have prominent psychiatric symptoms like confusion, psychosis, and depression. Finally, a few specific symptoms can help you differentiate primary adrenal insufficiency from secondary and tertiary adrenal insufficiency. Unlike secondary and tertiary disease, primary adrenal insufficiency is associated with aldosterone deficiency and salt wasting, which commonly causes salt cravings. As we'll detail in a little bit, aldosterone deficiency leads to profound dehydration, so patients with primary adrenal insufficiency present earlier than patients with secondary and tertiary adrenal insufficiency. Women with primary adrenal insufficiency may also report loss of libido or decreased pubic hair growth due to decreased androgen production by the adrenal glands. Men with primary adrenal insufficiency do not develop these symptoms because the testes produce powerful androgens independent of the adrenal gland. The presence of other pituitary hormone deficiencies, also known as panhypopituitarism, points towards secondary or tertiary adrenal insufficiency. Decreased TSH secretion from the pituitary leads to symptoms of hypothyroidism. such as cold intolerance and constipation. Decreased LH and FSH secretion from the pituitary leads to symptoms of hypogonadism. In women, this presents with irregular menses or amenorrhea. In men, look for decreased libido. Back on the primary set, we can see that the most common cause of primary adrenal insufficiency is autoimmune adrenalitis, hence the number 1 symbol, along with the antibodies incorporated into Miss Addison's chair. Autoimmune adrenalitis is an autoimmune process that destroys the adrenal cortex. Autoimmune adrenalitis may occur as an isolated disorder, but about half of patients have one or more other autoimmune endocrine disorders. Common co-occurring disorders include type 1 diabetes, vitiligo, primary ovarian insufficiency, and autoimmune thyroid disease, such as Hashimoto's thyroiditis or Graves' disease. The combination of autoimmune adrenalitis with autoimmune thyroid disease and or type 1 diabetes is known as autoimmune polyglandular syndrome type 2. Because why not? Tuberculosis can also cause primary adrenal insufficiency and is still a relatively common cause in developing countries. So we've brought in our recurring cavitary lung cactus. Mycobacteria spread hematogenously to the adrenal glands, causing inflammation and eventual destruction. Patients will typically have evidence of active tuberculosis infection elsewhere, usually the lungs. Look out for associated symptoms of fevers, night sweats, weight loss, and hemoptysis. Metastatic cancer can also cause primary adrenal insufficiency, hence the disseminating cancer crab legs falling from the crafts table. The adrenal glands have a rich blood supply, which makes them susceptible to cancer metastases. Both small cell lung cancer and breast cancer metastasize to the adrenals. More than 90% of both adrenal glands has to be destroyed before patients develop clinical symptoms. And we've brought in this fan's family to remind you to ask about a family history of autoimmune disease like autoimmune thyroid disease and type 1 diabetes. A family history of autoimmune disease is common in patients with autoimmune adrenalitis. Let's pan back over to the secondary and tertiary sets to focus in on some more past medical history. Any disease that affects the pituitary can interfere with ACTH secretion and cause secondary adrenal insufficiency, as well as panhypopituitarism. Conditions to watch out for include a pituitary adenoma, infiltrative diseases such as hemochromatosis or lymphocytic hypophysitis, hemorrhage into a pituitary tumor, also called pituitary apoplexy, and pituitary infarction due to excessive blood loss and hypotension at delivery, also called Sheehan syndrome. Any disease that affects the hypothalamus can interfere with CRH secretion, which in turn interferes with ACTH secretion, leading to tertiary adrenal insufficiency. Conditions to watch out for include tumors, infiltrative diseases such as sarcoidosis, TBI, and a history of cranial radiation. Get a medication history as well. The most common cause of tertiary adrenal insufficiency is chronic glucocorticoid therapy. This is actually a combined secondary tertiary mechanism, as glucocorticoids exert negative feedback on the hypothalamus to decrease CRH production, as well as negative feedback on the pituitary to decrease ACTH. Test questions are often tricky and don't explicitly state that a patient is on glucocorticoids. They instead mention Cushingoid features or medical conditions commonly treated with glucocorticoids, like rheumatologic diseases and obstructive lung disease with frequent exacerbations. Think of this ridiculously huge moon face as a chronic regimen of glucocorticoids crushing the hypothalamus and pituitary. It takes over 3 weeks of chronic high-dose steroids to suppress the hypothalamic pituitary adrenal axis and develop secondary adrenal insufficiency. But once this axis is suppressed, it may take 6 to 12 months for normal function to return. Therefore, patients who abruptly discontinue glucocorticoids may present with signs of adrenal insufficiency, either as a chronic presentation or adrenal crisis. I mean, just look at this guy here, who abruptly discontinued his steroids. Abruptly relieved of the weight of that moon, that is. See his shriveled hat? With so much negative feedback, no corticotropic hormones reached the adrenals and they atrophied. Get rid of his only source of steroids, and the adrenals just aren't ready to start producing steroids on their own yet. You have to slowly decrease steroid use, my friend. You can't just quit cold turkey. Alright, time for vitals and physical exam. Patients with primary adrenal insufficiency, remember, have aldosterone deficiency, and therefore excessive salt and water loss. These patients may have hypotension, especially postural and orthostatic hypotension. In primary adrenal insufficiency, look for signs of hyperpigmentation as a result of increased melanocyte stimulating hormone, or MSH. Loss of negative feedback on the pituitary gland leads to increased secretion of POMC, which then gets cleaved into ACTH and MSH. So, Miss Addison's assistant, unfazed by the disaster happening on set, busts out the MSH spray tan in between takes. In particular, look for pigmentation of skin creases, such as the palmar creases of the hands, areas exposed to light, such as the face, neck, and back of the hands, and areas exposed to chronic friction or pressure, such as the elbows, knees, spine, knuckles, waist, midriff, and shoulders. Hyponatremia is common in primary adrenal insufficiency, represented, as always, by falling salty peanuts. This is an effect of the combined aldosterone and cortisol deficiencies, which results in decreased mineralocorticoid action at the kidney. I know. But Ricky, hypoaldosteronism leads to salt and water loss. It's isotonic, you Hollywood hack. Okay, first of all, don't bash the lifestyle until you see the crummy, likely not earthquake safe apartment that I share with 4 roommates right across the smog choked 405 freeway. And second of all, remember that hypovolemia activates ADH release from the posterior pituitary, which conserves free water and dilutes serum sodium. Boom shakalaka! Hyponatremia. In patients with primary adrenal insufficiency, aldosterone deficiency may also lead to hyperkalemia and a mild hyperchloremic non-anion gap metabolic acidosis, symbolized here by the high-flying potassium bananas, as well as the acid volcanoes on set. Also assess for hypoglycemia. Remember that cortisol is a catabolic hormone that counteracts the effects of insulin. So, insufficient cortisol results in hypoglycemia, more common in secondary or tertiary adrenal insufficiency. The reason for this may involve the absence of hypotension with secondary and tertiary disease. This allows patients to tolerate their illness for longer. In primary adrenal insufficiency, hypoglycemia generally only occurs in the presence of other stressors, such as infection, fever, or alcohol ingestion. For primary, secondary, and tertiary disease, look for the presence of eosinophilia on a CBC. While this is not specific for adrenal insufficiency, allergies and infections will cause it too, it can be a clue. The first step in the workup of adrenal insufficiency is to actually demonstrate adrenal insufficiency, believe it or not. As we've seen, symptoms are vague and nonspecific, so it's important to be certain of the diagnosis before treating with steroids. First, check a cortisol level in the early morning, which is the time that cortisol levels are the highest. A cortisol level greater than 15 micrograms per deciliter makes adrenal insufficiency unlikely, while a level less than 3 micrograms per deciliter strongly supports adrenal insufficiency, as depicted by the down arrow on this sign for the AM shoot of the Court of Zal. Typical Oscar bait. Cortisol levels in between 3 and 15 are considered intermediate. If adrenal insufficiency is still suspected, order an ACTH measurement, but it takes a few days to come back. So, in the meantime, for patients with low and intermediate morning cortisol values, perform a high-dose cosentropin stimulation test next. Cosentropin is simply synthetic ACTH, so this is sometimes referred to as an ACTH stimulation test. This test measures adrenal gland response to high doses of ACTH. You give cosentropin and then measure cortisol 60 minutes later. A normal response is a post-cosentropin cortisol level greater than 18 micrograms per deciliter. Patients with primary and chronic secondary adrenal insufficiency will have a cortisol level that's lower than this. In primary adrenal insufficiency, the adrenal glands are diseased and can't respond to ACTH. In chronic secondary adrenal insufficiency, the adrenal glands are atrophied due to chronic lack of ACTH and also can't respond. This is depicted by the cosentropin co-director here, trying to get this Court of Zal actor back on set. Alas, he stays low. As I mentioned, this doesn't distinguish between primary and secondary adrenal insufficiency. The next step is to look at an ACTH level, which will be high in primary adrenal insufficiency, since the pituitary is still working, but low to normal in secondary and tertiary adrenal insufficiency. So, as you can see, on the primary set, the ACTH clapperboard is high, while on the secondary and tertiary set, the clapperboards are low. The ACTH levels should be drawn before performing cosentropin stimulation testing. but it takes time for ACTH results to become available. With the results of the cosentropin stimulation test and the ACTH level, you can start classifying patients into primary, secondary, and tertiary. Low cortisol and high ACTH equals primary adrenal insufficiency, while low cortisol and low to normal ACTH equals secondary or tertiary adrenal insufficiency. If initial cosentropin stimulation testing is intermediate, you can move on to perform more specialized testing with metyrapone or insulin tolerance testing. If primary adrenal insufficiency is suspected, measure serum aldosterone. Expect aldosterone to be low in primary disease and normal in secondary or tertiary disease. If primary adrenal insufficiency is identified, the next step is to determine the cause. To test for autoimmune adrenal insufficiency, measure anti 21 hydroxylase antibodies. These are positive in most patients, and a positive result confirms the diagnosis. An adrenal CT can be ordered to look for other signs of primary adrenal insufficiency, such as signs of infection, adrenal hemorrhage, or metastasis. How about a brief assessment before we move on? Miss Daisy is a 34-year-old woman presenting with weakness, fatigue, and weight loss over the past 6 months. In addition, she complains of occasional episodes of nausea and diarrhea over the same time period. She has no medical history and takes no medications. Vital signs are significant for a heart rate of 95 at rest and a blood pressure of 98/64 sitting, which decreases to 81/60 upon standing. Physical exam is significant for hyperpigmentation of the neck, arms, and hands. Labs are significant for a sodium of 131 and potassium of 5.4. Given Miss Daisy's exam findings and electrolyte abnormalities, I'm most concerned about chronic primary adrenal insufficiency. Alright, now on to treatment of chronic adrenal insufficiency. In a nutshell, your job is to replace the missing steroids. Regardless of the cause of the adrenal insufficiency, all patients need glucocorticoid replacement. So, through this trap door, we are bringing in our symbol for glucocorticoids, that eerie moon face. You can use hydrocortisone 20 mg in the morning and 10 mg in the early evening to mimic normal diurnal secretion. Alternatively, you can use prednisone 5 mg once daily for simpler dosing. Titrate replacement to the lowest dose that relieves symptoms and minimizes hypercortisolism side effects. Remember that patients with primary adrenal insufficiency also develop aldosterone deficiency, so they require mineralocorticoid replacement as well, as emphasized by the mineral headdress. Patients with primary adrenal insufficiency should be on a mineralocorticoid like fludrocortisone once daily. You can titrate the dose by measuring the plasma renin level and targeting an upper normal level. Patients with adrenal insufficiency typically need increased steroid doses during illness or surgery. Times of stress when their crappy adrenals just can't bump up the cortisol sufficiently. Patients with an illness, such as an upper respiratory infection, are usually advised to increase their home dose of steroids to about 3 times the normal dose for 3 days. The so-called 3x3 rule. If the patient feels they cannot return to a lower steroid dose after 3 days, they should seek medical attention. Additionally, stress dose steroids are administered to patients before surgery, with the dose depending on the severity of the operation. This is usually in the form of IV hydrocortisone. Patients on supraphysiologic doses of glucocorticoids, those on 20 mg per day of prednisone or its equivalent, for 3 weeks or more should be presumed to have tertiary adrenal insufficiency from HPA axis suppression. These patients will need stress dose steroids. Patients on less than 5 mg per day of prednisone or its equivalent are highly unlikely to have a suppressed HPA axis and do not need stress dose steroids. Those on intermediate doses may need to be evaluated for tertiary adrenal insufficiency with an early morning serum cortisol level and possibly even a cosentropin test to determine if they'll need stress dose steroids with surgery. If there's no time for the test, these patients can be given stress dose steroids as a precaution. Alright, let's wrap up this shoot with acute adrenal insufficiency, also known as adrenal crisis. It can develop in patients with underlying primary or secondary or tertiary adrenal insufficiency, presenting with signs and symptoms of distributive shock. Adrenal crisis may be the initial presentation of previously undiagnosed chronic primary adrenal insufficiency, usually precipitated by a stressor such as serious infection, trauma, or surgery. In patients with any type of adrenal insufficiency, Adrenal crisis may occur if a patient is taking insufficient glucocorticoids and or mineralocorticoid replacement therapy. This includes failure to take extra glucocorticoid during surgery or illness. In patients with tertiary adrenal insufficiency from HPA suppression by exogenous glucocorticoids, abrupt withdrawal of glucocorticoids can cause adrenal crisis. Also, any acute insult to the pituitary or hypothalamus causing acute secondary or tertiary adrenal insufficiency can cause adrenal crisis. Think of the acute infarction of the pituitary in Sheehan syndrome or pituitary apoplexy. Adrenal crisis can occur as a result of acute bilateral adrenal gland destruction, such as bilateral adrenal hemorrhage, also called Waterhouse-Friderichsen syndrome. This is classically associated with meningococcemia, though it occurs with sepsis from multiple other bacterial pathogens. The major risk factors are anticoagulation, even if within therapeutic range, or an underlying coagulopathy, such as antiphospholipid syndrome. Adrenal crisis presents with a bunch of nonspecific symptoms, almost like a more severe version of adrenal insufficiency. Expect nausea and vomiting, abdominal pain, which can be severe, lethargy, and confusion. Basically, patients are hemodynamically unstable and look like crap. Patients with acute adrenal insufficiency present with shock, so look for hypotension. The hypotension is often refractory to IV fluids and vasopressors. On physical exam, look for hyperpigmentation as a sign of long-standing primary adrenal insufficiency. Hyperpigmentation will not have time to develop in acute adrenal hemorrhage. Also assess for Cushingoid features, which might be a clue that the patient has been on chronic steroid therapy. Labs will be similar to chronic adrenal insufficiency. Hypoglycemia may be seen in secondary and tertiary adrenal insufficiency. Cortisol and ACTH labs can be drawn, but don't wait for the results before treating. Alright, let's sum up the presentation for acute adrenal insufficiency, which will help contrast it from the chronic version. Ava Intel is a 38-year-old obese female with a history of lupus presenting with abdominal pain, nausea, vomiting, and weakness for the past 6 hours. She's been complaining of dysuria and urinary urgency for the past 3 days. Her home meds include hydroxychloroquine and prednisone for lupus, which she's been taking for the past 7 years. Vital signs are significant for a blood pressure of 80/50, heart rate of 110, and respiratory rate of 20. Physical exam is significant for dry mucous membranes and diffuse abdominal tenderness. Labs are significant for a sodium of 130, potassium of 5, BUN of 35, and creatinine of 1.5. UA is significant for positive leukocyte esterase and nitrates. Given Ava's history of chronic glucocorticoid therapy, her symptoms and lab findings are most concerning for acute adrenal insufficiency, likely triggered by a UTI. If you suspect adrenal crisis, don't delay treatment. Confirmatory testing can wait until the patient is stabilized. Treat adrenal crisis with 2 to 3 liters of IV normal saline boluses and IV glucocorticoids. Use either dexamethasone or hydrocortisone. Dexamethasone is preferred for patients without a prior diagnosis of adrenal insufficiency because it won't affect future cortisol measurements. Mineralocorticoid replacement for primary adrenal crisis isn't necessary acutely since it takes a few days to kick in, and the IV normal saline provides enough of a salt load. As you're stabilizing the patient, search for a trigger. Specifically, do a thorough infectious workup with blood cultures, chest x-ray, and urinalysis. Have a low threshold to start empiric antibiotics. Once the patient has stabilized, formal testing for adrenal insufficiency needs to be performed if they do not already have a diagnosis. This testing is the same as for chronic adrenal insufficiency. Long-term treatment is also the same. Once the patient stabilizes, convert to oral steroids. In primary adrenal insufficiency, a mineralocorticoid will also need to be added. Alright, let's wrap up this sketch with a brief recap of what we've learned. Adrenal insufficiency comes in 3 flavors. Primary adrenal insufficiency, aka Addison's disease, in which the adrenal glands themselves are to blame. Secondary, which refers to pituitary disease leading to adrenal malfunction. And tertiary, which is caused by diseases affecting the hypothalamus. Regardless of the cause, adrenal insufficiency can present chronically or acutely. Chronic adrenal insufficiency presents insidiously, with nonspecific symptoms like fatigue, weight loss, nausea, and muscle or joint pains being the most common presenting complaints. Autoimmune adrenalitis is the most common cause of primary adrenal insufficiency in developed countries, whereas TB involvement of the adrenal glands is the most common cause of primary adrenal insufficiency in areas where TB is endemic. When it comes to secondary and tertiary causes of adrenal insufficiency, look for tumors and infiltrating diseases of the pituitary and hypothalamus. Symptoms of panhypopituitarism will help point you towards a secondary or tertiary cause of adrenal insufficiency rather than Addison's. Physical exam of patients with chronic adrenal insufficiency may be pretty unremarkable. The classic exam finding of chronic Addison's disease is hyperpigmentation of the skin, especially in sun exposed areas such as the face, neck, arms, and hands. Typically, patients with primary adrenal insufficiency will have hyponatremia, hyperkalemia, and non anion gap metabolic acidosis on labs, all due to decreased mineralocorticoid activity. When you see that classic pattern on labs, adrenal insufficiency should be high up on your differential, and you should follow up with an early morning cortisol level as a screening test. For patients with a low or intermediate early morning cortisol level, the next step should be an ACTH, aka cosentropin, stimulation test. A low cortisol response to ACTH stimulation cinches the diagnosis of primary or secondary adrenal insufficiency. From there, grab a serum ACTH level to distinguish between primary and secondary adrenal insufficiency. Once you've diagnosed chronic adrenal insufficiency, treatment is pretty straightforward. Glucocorticoid replacement therapy. In patients with primary adrenal insufficiency, you'll have to replace mineralocorticoids as well with fludrocortisone. Lastly, if patients with chronic adrenal insufficiency need surgery or get really sick, they'll need stress dose steroids to make up for what their adrenal glands aren't able to produce. Speaking of which, that brings us to acute adrenal insufficiency, also known as adrenal crisis. Acute adrenal insufficiency most commonly occurs when patients with chronic adrenal insufficiency experience an acute stressor, such as surgery, trauma, or serious infection. Usually, your patient will be someone on chronic glucocorticoid therapy, either as replacement for primary adrenal insufficiency, or more commonly, as an anti inflammatory agent for a variety of conditions, including any autoimmune diseases. The most common presentation of acute adrenal insufficiency is acute onset of abdominal pain, nausea, vomiting, and weakness shortly after a significant stressor. They'll usually be significantly hypotensive, which is a big deal. Circulatory collapse is what kills these patients. They'll also have the same electrolyte abnormalities as patients with chronic adrenal insufficiency. When you suspect acute adrenal insufficiency, don't wait, act. The two staples of initial management of acute adrenal insufficiency are IV fluids and IV glucocorticoids. Then, once you've stabilized their circulation, start looking for the underlying trigger of their acute presentation. And cut! All right, people, that's a wrap. Hey, Brayden, that gut punch to the alien back there, it was good, but I didn't feel the emotion behind the punch. You know what I mean? Like, when you listen to Seals Kissed by a Rose, oh, that is raw emotion. I want to feel that when you punch the alien in the abdomen, okay, champ? You know, he's not married to Heidi Klum anymore. Yeah? Maybe he's angry about it? Maybe angry enough to punch an extraterrestrial in the midsection, perhaps? Look, I don't know. I'm not Seal, okay? But what I do know is that we gotta get you in the right headspace. You just do whatever it is you need to do, and we'll do another take when you're ready. I've been cursed by